Melissa, thank you very much. So in full disclosure, you may or may not know, about 3 weeks ago, Stretta was no longer available. So if you want to take a 5-10 minute nap, I won't feel offended. But I'll start with a little bit of a funny story. So I'd heard this and I'm like, oh geez, well, what am I going to do? So I went on the internet, I looked for some information. Maybe there's bankruptcy proceedings or something I could share with you. And actually, there was nothing. So I called the company. And I got an answering service in Bozeman, Montana, of all places. And when I asked the answering service if they could please patch me through or leave a message for somebody from Maderi to call me back, their answer was, I'd be happy to, but I can guarantee you they will not call you back. So advice from the past. I always like to look back at history. Illnesses that are not cured by medications are cured by surgery. Those not cured by surgery are cured by cautery. Those not cured by cautery should be considered incurable. And so much of this actually rings true today. So when you look at the role of the lower esophageal sphincter in the hiatal hernia and the pathogenesis of reflux disease, as Dr. Perry had mentioned, it's a combination of things. One of the things, most important lessons I learned about reflux is think about it as a pump valve and reservoir. The pumping, the esophagus, the valve being the sphincter, and the reservoir being the stomach, and the interplay between the two. But you can see, as you can see here, the effects of a hiatal hernia and a defective LES in the prevalence of increased esophageal acid exposure. And there's a gap, and the gap, we've been talking about the gap for years. Why the gap remains, I think, is multifactorial. One of the biggest things I'll talk about a little bit later is the bias. And when I talk about bias, I'm talking about not only patient bias, but referring physician bias. Bias by gastroenterologists and bias by primary care providers. As you know, there's about 700,000 reflux-related upper endoscopy procedures per year in this country, but there are only about 200,000 evaluated for anti-reflux surgery, but only about 70,000 cases per year. So what are the indications? And I think this is an indication for any endoluminal procedure when you're talking about reflux. Someone who has subjective and objective findings of gastroesophageal reflux disease in whom you or they do not want an operative procedure. And we start to see this, a lot of patients get referred and just say, I don't want surgery. I want you to do something for it, but you're not going to operate on me. This may be a high-risk patient, an overweight patient, because the failure rates with some of the procedures with obesity or anatomic issues that are associated with fundoplication that Dr. Perry alluded to as far as additional procedures. So radiofrequency is not, there's nothing special about radiofrequency. It's just a little bit different in the radio spectrum. A little bit below AM and FM radio, pagers, television, and things like that. The economics I talked about, we showed up in 2000. CPT was assigned in 2004, but then it went away back in 2006 when Curon filed for bankruptcy. Resurfaced in 2008 with Maderi Therapeutics. Actually, April 12, 2010 was the relaunch date, and then it exited just within the last couple of weeks. So. Apologize, I had nothing to do with it. So what is it? It's actually temperature-controlled radiofrequency delivery of energy, and it delivers energy in the submucosal space while it bathes the outside or the mucosa in cooling liquid to kind of protect it from full thickness thermal injury. It's temperature-controlled with thermocouple monitoring, and the power output is regulated by a computer algorithm. You don't have to really know the ins and outs because it's quite simple to use. But you can see here in this H&E stain of an acute lesion in the muscle at the GE junction that shows the kind of the buildup and the thickening. And this is what it looks like from the inside. The baseline appearance of the LES on the left, and this is immediately after Stretta. You can see this swelling, for lack of a better word, in the submucosa that tends to help bulk up the lower esophageal sphincter. This is what it looks like immediately in a retroflex view. You can see the relative hiatal hernia on the left with the bulking up of the lower esophageal sphincter on the right. And this is, there's some sustainability in this. And this is a 6-month view after Stretta on the right-hand side. And actually, if you look at some H&E stains 6 months post-treatment, and you can see the increase in the thickness of the submucosal space. This is what the bias that I referred to earlier. I think there is a bit of a PCP and a GI bias toward distant fundoplication because of patient stories and feedback that they get from their patients. Many patients are fearful of the dysphagia, the gas bloat, and some of the challenging outcomes that they hear about. There's increasingly chat rooms, blogs that are out there for people with reflux disease or people, it's very, very common in bariatric surgery as well. And I think we kind of need to be sensitive to what's kind of going on behind the scenes. We're talking about the biases for these patients. So here's this is a patient, a 56-year-old, and this is a perfect patient you may want to consider other alternatives for. 56 years old, type 2 diabetic, overweight, reflux for 8 years, is controlled with a PPI, but she's had multiple abdominal procedures, and she comes and she's sent to you because she is not interested in surgical procedures, and you may not want to offer her a surgical procedure. Standard workup, gastric emptying study, I would recommend in many diabetics, but 24-hour, whether you do Bravo or just 24-hour esophageal pH testing, I think either is good. And these are the options, and Dr. Revis alluded to them earlier. This is what I consider the 5 options in 2018. They either get a Nissen, they either get a Lynx, they either get on the FDA Endostim trial, an esophagus or TIF procedure, or Stretta, which is obviously not available. So in the interest of time, I will stop there. And thank you very much for your attention. And I want to thank Sages and Melissa for the opportunity to present and talk.